Good evening. My name is Heidi White, and I am the Group Fitness and Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate our wellness speaker series, including tonight's presentation, The Lowdown on High Blood Pressure, with Dr. Jennifer Cluett and Dr. Anna Krawisz. Dr. Cluett is an assistant professor of medicine at Harvard Medical School, a general internist, and a certified hypertension specialist. She is the medical director of the Complex Hypertension Center at Beth Israel Deaconess Medical Center. Dr. Krawisz is an instructor in medicine at Harvard Medical School, the lead cardiologist at the Beth Israel Deaconess Medical Center Complex Hypertension Clinic, and a member of the Smith Center for Outcomes Research in Cardiology. Just a few things to note about our webinar setup. Our presenters can't see or hear you, and participants can't see or hear each other. The chat function has been disabled, so please type your questions using the Q&A feature for any questions you may have during the presentation. And with that said, I'm going to turn things over to Dr. Krawisz and Dr. Cluett. You guys can share when you're ready.
Great. Thank you, Heidi. I presume everybody can hear me. We are really excited to speak to you tonight about blood pressure, which is a topic that both Dr. Krawisz and I spend a lot of our time thinking about and treating in our everyday jobs. We are going to have about 10-15 minutes of content about high blood pressure, and then we'll take a break to answer your questions, but go ahead and submit questions as they come to you into the Q&A, and we'll stop after a little bit to answer those questions, and then we're going to do a blood pressure demonstration after that on this Zoom, and we'll answer any questions you have from that blood pressure demonstration at the end of that. So without further ado, Dr. Krawisz, if you would like to get us started.
Sure. So thanks so much, Jen. So just going to start with the basics. I know we probably have a really wide range of backgrounds and education levels about hypertension. And so we'll go more into detail with topics based on questions. But just to kind of start out with, what is blood pressure? And so it's really the force generated, by the heart, used to propel blood forward in your arteries. So a measure of blood pushing against the walls of the arteries. And so blood pressure has two numbers, as many people probably know. The top number is the systolic pressure. It's called the systolic pressure, and that's the pressure in the arteries generated when the heart beats, or contracts. Same thing. So when the heart beats, you get the top number, the systolic blood pressure. And then when the heart rests or relaxes between beats, that generates that bottom number of pressure, which is lower, and that's called the diastolic blood pressure. And so what is high blood pressure, or hypertension? And so it's really normal blood pressure is really anything with top number less than 120 or bottom number less than 80. And this has sort of come down over time based on some clinical trials. And so elevated blood pressure is a top number between 120 and 129, and a bottom number less than 80. And then we get into hypertension, which is sort of divided up into categories in the most recent guidelines. And so a top number of 130 to 139 or a bottom number of 80 to 89 is known as stage 1 hypertension. And then above that, we call it stage 2 hypertension, essentially. And so, what is important here and what is a goal blood pressure for most people, and one that we use in our practice, it's really less than 130 for the top number and less than 80 for the bottom number. And so overall, the guidelines recommend this for adults with cardiovascular disease or or atherosclerotic risk factors of greater than 10% or more over a 10-year period. But this is really what we feel is a good goal for all adults, less than 130 over 80. And this has really come down over time based on clinical trials, especially one called the SPRINT trial that looked at intensive blood pressure lowering versus sort of what was previously considered standard lowering. And so now we know based on clinical trials, you know, in 2016, 2017, that a lower blood pressure goal is better. And this is what we use now based on that research and information. And so a little bit about the scope of the problem of hypertension in the United States. So actually almost half of all US adults have hypertension. So this is National Health and Examination Survey information. So NHANES survey data of people in the United States from 2017 and 2018. And over on the left bar graphs, that includes all patients or all people 18 and over in the navy blue graph with the red arrow. So you can see that 45% of US adults have hypertension based on this definition. And hypertension increases with age. And so when you get to the gray bar, which represents 60 and over, all of a sudden 74.5% of people have hypertension. So whenever people come to see me, you know, they're always like, why do I have this? Why do I have hypertension? You know, what did I do? You know, and I always tell people it's really, really common. It's just a very common problem. Men have more hypertension than women. Really, that's only true at younger ages. When men and women get to 60 and over, you know, women are at about 74%, men are at 75%. There is a racial difference in hypertension. So Black adults are disproportionately affected. So when you look at all adults over 18, 57.1% of Black adults, you know, relative to, they display Caucasian and Hispanic as the comparisons. And we really don't do a good job of treating hypertension. So overall, the majority of hypertension is uncontrolled in the United States. And actually, this is more recent data. It's from 2020. And so now 48%, that's come up from that 45% of adults as of 2020 in the US have hypertension. And that red bar shows you that 77.5% of all hypertension is not controlled or not at goal numbers or values. So this is really something that, you know, overall as a nation and in medicine, we need to confront. You know, and why should we care about this? Why is this important? And, you know, I think a lot of people know this very well, but overall, hypertension leads to a lot of different problems. And the three most notable ones are stroke, heart failure, and heart attack. And heart failure in particular, about 40% of the attributable risk for heart failure is from hypertension. So really treating hypertension better means eliminating strokes, eliminating heart failure, and eliminating heart attacks. You know, there's some other ones mentioned here: vision loss, kidney failure, sexual dysfunction, you know, lots of different physiological systems are connected to blood pressure in the body. And a few statistics. So for every 20 millimeter of mercury or 20-point increase in the top number that people have of blood pressure, your risk of cardiovascular events doubles. And for every 10-point increase in the bottom number, your risk of cardiovascular events doubles. And then if you have individuals with and without hypertension that are otherwise matched for age and comorbidities, and one group has hypertension, they have about an almost threefold elevated risk of mortality from cardiovascular disease.
So moving on a little bit to how we treat high blood pressure. One of the things I always say to patients when they come in is, I want you to be on the least amount of medication that's going to keep you healthy and prevent some of those things that Dr. Krawisz was mentioning, like heart attacks and strokes and heart failure. And so first and foremost, we spend a lot of time talking to patients about the different aspects of lifestyle that can help lower blood pressure. And it's one of the things that really attracted me to hypertension as a field, because I think it's so important to be able to combine lifestyle changes along with things like medications. Exercise is one of the most important things that you can do, and the recommendations from the American Heart Association are to get 150 minutes each week over the course of a week of moderate intensity exercise, or 75 minutes per week of vigorous intensity exercise. And it's sometimes hard to describe what the difference is between the two of those. Vigorous intensity exercise is something like you might be running at a faster pace. You are unable to say a few words without stopping to take a breath. Moderate intensity would be more of a brisk walk, where you couldn't complete a full sentence without taking a breath, but you might be able to still say a few more words. And so if you can achieve that level of exercise each week, it's about the equivalent of taking a blood pressure medication at about half the maximum dose, which is makes a really big difference, but it's something you've got to be able to fit into your life and commit to and get over time. In terms of a healthy diet, we're going to talk a little bit more on the next slide about the specifics of what that means exactly. But making dietary changes, specifically lowering the sodium in your diet, and increasing the healthy amounts of potassium in your diet, can help lower blood pressure. Limiting alcohol, and the recommendations are no more than 2 drinks per day for men and no more than 1 drink a day for women. And so some people say, oh, that's 7 drinks a week. Can I, have a couple on the weekend? And so for women, if it's 7 drinks per week, it's really no more than 1 per day. Even if you're having more than 1 on a given day, a few times, that can raise your blood pressure on the days even that you aren't drinking as much. So it's important to if you can, cap it at those limits: 1 alcoholic beverage per day for women and up to 2 for men. If you smoke cigarettes or use nicotine or tobacco, quitting smoking can lower your overall cardiovascular risk and can lower blood pressure. And then maintaining a healthy weight. So we think about weight usually in terms of body mass index, which is a calculation that includes both your height and your weight. But achieving and maintaining a healthy weight can help lower blood pressure. And for many people, the first 5 to 8 pounds of weight loss can have the biggest impact on their blood pressure. And so for each kilogram that you lose with the first 5 kilograms, you can take 1 point off that top number, the systolic number that Dr. Krawisz described.
Just a quick question that came up. Can you just repeat the exercise definition?
Oh, sure. 150 minutes a week of moderate intensity exercise. So I think about that as 30 minutes, 5 days a week, but you can break it up however works for you. What's important is that it works for you. It's something that you can commit to and sustain. So 150 minutes a week of moderate intensity, or 75 minutes a week of vigorous intensity. Sometimes people come in and they say, oh, well, I walk my dog, every day. I have a yellow lab. He's a dawdler. Walking him is not moderate intensive exercise, and it is certainly not vigorous exercise. So it really has to be, to count as moderate intensity, you have to really be pushing the pace a little bit. And for vigorous, you need to be doing something. I use examples like a fast run, some people have spin bikes or things like that. You need to be doing like a HIIT class might meet criteria for vigorous intensity. Thanks, Heidi. I'll keep an eye on the chat. And then lastly, getting a good night's sleep. So this is a newer recommendation from the American Heart Association. They have these different categories of things, and the having a better appreciation of the importance of good sleep on our cardiovascular health is a relatively new discovery, and something we're definitely talking to people more about. But it is really important to try to address and assess for any underlying sleep issues, because getting good, healthy sleep we've learned is very important for cardiovascular health. So moving on, if we've exhausted all of our lifestyle changes and your blood pressure is still not at goal, prescription medications are often necessary. And like Dr. Krawisz was describing earlier, patients come in and they say, why do I need to take a medication for this? This is such a common problem. It is one of the most common reasons for prescription medications and outpatient office visits is for blood pressure treatment. Some things to note, most patients are going to need at least 2 or up to more, 3, 4. We have patients even on 5 and more medications to control their blood pressure. And so I think people get frustrated. They are on 1 medicine, they're not at goal, 2 medicines, but that's the norm. In fact, for some of the clinical trials that Dr. Krawisz was referencing, the average was about 3 medications per person in order to achieve those good blood pressure goals that people were trying to get to. The medications are generally taken long-term. Sometimes people ask, how long do I need to take this? And I always use the analogy of an antibiotic. These aren't antibiotic medications. You can't take them for a while and then their effect has happened. You need to continue to take them. And if you stop taking them, they stop working. So it is something that most people need long-term. And as I implied earlier, they do need to be increased or adjusted over time. And I think that first graph that Dr. Krawisz showed about the prevalence of hypertension as we age, as we get older, our blood pressure tends to rise. And even if we are a goal in 1 year or decade, we often need more medication to maintain those goal blood pressures as we get older, just due to age-related changes to our blood vessels. There are new medications and new treatments that are available. Hypertension has been around for a long time, and many of our medications are old and well studied, which I think is wonderful. But just in the past 2 to 3 or more years, there's been new medications that are in the pipeline that we're very excited about. We have some clinical trials at our hypertension center, both for new medications, but also for new treatments. There's a new procedure that's called renal denervation that was just approved by the FDA in November as a procedure-based treatment for hypertension. And this is really new and cutting edge. We're one of the only centers that are doing this in Boston or New England. And we are offering that now through our hypertension center, which is really exciting. I'm going to pause just to take a question that I saw came up, Anna, in the chat about swimming and rock climbing and hiking and walking and doing Zumba. Julia, those are all wonderful exercises, and some of those are going to have differing effects on lowering your blood pressure, just depending on the level of exertion that you're getting to. Hiking, obviously, it depends on the strenuousness of the hike. There is no bad exercise, okay? So anything you're doing out there is helping. The issue is more around if your goal is specifically to lower blood pressure, it's good to try to hit those targets that I was talking about. But all of those other things are helping with bone density, with endurance, with so many other mental health. All of those things are really wonderful exercises to do. There's no bad exercise. It's just the ones that I mentioned have the best data about their ability to lower our blood pressure. John, I'm going to wait to take your question when we stop for the Q&A and talk a little bit more about diet. So what exactly is the DASH diet? Some of you may have heard about this. It is a very specific diet that has been shown to lower blood pressure. And it's actually one of the lifestyle things that can have the largest impact on blood pressure, up to somewhere between 8 to 20 millimeters of mercury. And that's 8 to 20 points off that top number, which is a huge impact. But the DASH diet is a very specific diet. It stands for the dietary approaches to stop hypertension. It's high in natural sources of potassium, calcium, and magnesium, and it's low in sodium, saturated fats, and added sugars. And I describe it as a dietary pattern, and that's because the DASH diet can be applied to almost any other diet that you might choose to follow, be it a cultural, if you can have a diet that meets the criteria of the DASH diet from almost any ethnic, or different ethnic diets or cultural diets. So different countries, or even sort of like different areas of this country where diets tend to be quite different. You can find elements of those diets that can still fit into a DASH diet, or Asian or Indian, or any sort of diet. Mediterranean is an example of a diet that's very naturally fits with a DASH diet. But you can apply these principles to almost any cultural diet that you might enjoy. And so it's not prescriptive in that way, but it can be, features of the DASH diet can be applied to almost any type of diet. So this is important. Up to 20% of us are taking medications that raise our blood pressure. And oftentimes we don't know that they're raising our blood pressure, or our doctors or nurse practitioners may not even know that we're taking them, because many of them are over the counter. And so I just want to mention these, and something we go over with every patient that we see. Many over-the-counter pain medications can raise blood pressure, specifically medicines like ibuprofen or Motrin, Aleve, naproxen, medications in those categories. And so patients will ask, I can't take those. And I'll say, no, it's not that you can't take them. It's just, you need to know that they impact your blood pressure, and, consider trying an alternative medication before you reach for that. Some of those medications also interfere with some prescription medications that we use to treat blood pressure. And so it's almost like a double whammy. They're both raising your blood pressure temporarily, but they're also making your own prescription blood pressure lowering medications less effective. Some cold medications, ones to treat sort of nasal congestion, like pseudoephedrine, raise blood pressure. Caffeine is always a big question. If you drink a cup of coffee a day, I'm never going to tell you to stop doing that. It's more sort of the higher caffeine and more episodic caffeine or energy drinks like Red Bull, or I think Celsius is another one that the cool kids are doing these days. People are coming in telling me about. Some over-the-counter weight loss supplements can raise blood pressure. They work almost like stimulants. Some different types of herbal supplements. Birth control is a big one. So any birth control that contains estrogen can raise blood pressure. And sometimes the doctor that's treating your blood pressure may not know that you're getting hormone replacement therapy or birth control from your gynecologist or your obstetrician in a different system. So just making sure that the doctors who are treating your blood pressure know about all of the medicines that you're taking, both prescription and over the counter. And then obviously some street drugs. Even marijuana and other street drugs can be associated with high blood pressure. Anna, Dr. Krawisz, do you want to take this?
Yes. So Jen and I, one of the things we do is, we see hypertension, but we are working to assemble a hypertension center where we have a lot to offer patients on multiple levels of treating hypertension, from counseling on lifestyle modifications, to changing medication doses, to treating underlying medical conditions that contribute to hypertension, and then also offering more advanced therapies for hypertension, so clinical trials and procedures. And so, when should somebody go and see a specialist? Because primary care physicians are well equipped to manage hypertension in many circumstances. And I'll start by saying anytime somebody's blood pressure is not well controlled, that's a good enough reason to see a specialist, because we really want to try to get everybody's blood pressure well controlled. And then some of the more specific things. So if blood pressure is very high, so, top number 170 or above, in those really, really high numbers, I think that would be a good reason to see a specialist for a workup. If somebody is on a lot of medications, what does that mean? More than 3, 4, 5, that's a good reason to be evaluated by a specialist for some of these advanced treatments and or medical conditions that might be contributing. And again, evaluation for these medical causes of hypertension or medical contributors to hypertension. And then somebody seeking more advanced therapies, be it medications that are only available in clinical trials or procedures. And Jen sort of alluded to renal denervation. And there are some other aspects of hypertension that are treated procedurally. And so if anybody would like to refer to us or come to our center, this is the information, and we can certainly circulate that.
One thing I'll add, Anna, to the reason to see a specialist is if your blood pressure has been well controlled for a long time and then all of a sudden there's an abrupt change, that's often a clue or a hint that there's something else going on. And, you always start with your own clinician, but that's another reason why we frequently see people. I did mention that as we get older, our blood pressure tends to rise. And so sometimes medications need to be adjusted, but if there's a sudden and very sharp change, or if you have new high blood pressure at a very young age, or an older age, that's a little bit unusual as well. So I see some questions in the chat. Maybe I'll read those and then Anna, we can take them. The first one is why
do you want to just stop sharing your slides so your picture can be bigger for a moment?
Yes, great idea.
Why do you think there's such a high level of hypertension that isn't controlled in this country? Is it lack of knowledge or lack of access to healthcare?
Yeah, I think this is a really important question with answers on sort of multiple levels. So I think the answer ranges from, one, I think a lot of things that are treated based on urgency. So somebody could go a long time having, more urgent issues treated and having hypertension that wasn't necessarily addressed. I think a lot of times office blood pressures can be misleading. A lot of times office blood pressures appear elevated and people's blood pressures are normal at home. And so you could see a physician and they may, somewhat appropriately not readily diagnose hypertension from one elevated office pressure. So I think these things can go unnoticed if not looked for in sort of a pattern. So sometimes the diagnosis can be complicated. And then I think, hypertension can be challenging to treat in the sense that, you heard there's sort of multiple levels of treatments involved in hypertension. And I think that that's, a lot of time, requires a lot of different types of medical practitioners, and a lot of different types of interventions for patients. And I think that there are healthcare disparities and health inequities that contribute. We do see racial differences in hypertension. And then overall, I think just something that is so common and where so many people are impacted. I think that it just isn't, done in a systematic fashion in our medical system.
High blood pressure is called the silent killer. And so most people who have it don't have any symptoms of their high blood pressure. And so it's really hard to take medication every day for something that you don't feel bad having. And so I think there's that's an issue, like Anna mentioned, underdiagnosis, because people don't have symptoms, they're not being diagnosed. And like I said, it's hard to take something every day for the rest of your life for something that isn't causing any symptoms on a day in and day out basis. So I think there's a lot with that. The next question is about a blood pressure that is one day good and the next day is as high as 145/75. So it really fluctuates and at different times of the day. And I'll start and then I'll let you, Anna, if you've got, have you add in as well. I always, people are frustrated by this a lot. And it's normal, right? Blood pressure is variable, much like our heart rate, and it varies minute to minute, hour to hour, day to day, season to season, and it varies on the basis of so many different things. And we'll talk about some of those things when we talk about how to check your blood pressure properly. One of the things we really have to do is to try to minimize some of those variables when we're checking blood pressure properly. But it can be very normal to have blood pressure variation. Ideally, that variation is within that normal range, or you maybe in the top normal range and down. So people might have a lot of variation, but ideally that variation is on the lower end of that scale. So sometimes if you are fluctuating, it really depends on what percentage of the time it's high versus not high. And we do some testing like 24-hour blood pressure monitoring, where we'll get a picture over the whole 24 hours while you're sleeping and while you're awake of what your blood pressure looks like, so that we can let you know if the variability that you have is normal or abnormal or concerning in any way. Sometimes really variable blood pressures can be the sign of a serious underlying health condition and need to be evaluated. And they're more common in people who are older. There's a lot more variability in patients who are older. But other thoughts on that one, Anna?
No, but I think that just also highlights why hypertension can be undertreated. I think it's a moving target, and I also think people are worried about over-treating and doing harm by treating somebody too intensively, and so I think blood pressure, it is a variable metric. And a lot of times we have testing that gives you kind of like a binary yes or no answer. I have this, I don't have this, whereas blood pressure, takes a little bit of finessing. It takes work to measure it multiple days in a row to average those measurements. So I think, as Jen said, it's normal to have some variation. And I think that just adds another element of difficulty to, diagnosing hypertension initially, and also sort of verifying that it's been appropriately treated.
The last question we have in our—
I was going to say, just related to that, how do you know if you're taking it at home, how do you know when your cuff that you're using is accurate?
Well, that's a great question. One way to know is to bring it in with you to your doctor's office so that it can be compared when you're in the office using the ones there. There are some email lists. FDA approved for blood pressure cuffs actually means very little, so I would not go by FDA approved. Some of the direct-to-consumer lists like Wirecutter and Consumer Reports may not actually be high quality or accurate blood pressures. They may be, but they aren't necessarily. There's a website. It's can I put it into the chat, or it's called www.validatebp.org. It's a website that's sponsored by the American Medical Association, and it lists different types of home blood pressure cuffs that have been independently validated by a group of hypertension specialists like me. We certify those blood pressure cuffs as being accurate and valid. We actually review the manufacturer's data compared to international standards for validity. And that's a good resource if you're looking to get a new blood pressure cuff. But that's a great question. Even blood pressure cuffs that aren't on that list might be accurate, which is why, Heidi, I recommend that if you have one and you're not sure, I usually tell people at least once a year, bring it into your doctor's office and make sure that it's at least in the same ballpark.
Yeah. And I can send that site to the people who registered for tonight's event. I don't think the chat is working, but I'm happy to
we have a question, Dr. Krawisz, if you could take this. Why might someone need more than one medication to lower their blood pressure?
Yeah, so that's a great question. And So each blood pressure medication might get you, 8 to 10 points of medication lowering. So that's one part of the answer. It depends on how high your blood pressure is to start out with. So, if your blood pressure, if the top number is in the 160s, we sort of anticipate that you're going to need 3 medications to just sort of, numerically bring that down. And then another part of this is sort of mechanistic. So the medications actually work better when they're used together because they work on different aspects of our physiology. And as opposed to maxing out one medication and just using kind of one method of changing the body, if we do kind of multiple complementary mechanisms, then those work together to actually kind of get synergistic lowering of the blood pressure.
Any other questions?
Maybe we'll share our screen again and go through some of the elements that we talk to patients about, checking your blood pressure at home, and then we'll do our demonstration. So a little bit about blood pressure measurement in and out of the office. As it turns out, if you Google pictures of people getting their blood pressure measured, there are plenty. In fact, the vast majority of them include things that are being done incorrectly. And these are just some great examples of that. We'll go through why that is as we go through the next slide, but each of these is demonstrating some things that might cause the person who's getting their blood pressure measured to be higher than it really is. You want to go to the next slide? So here are some factors. So if your legs are crossed, that can raise your blood pressure anywhere from between 2 to 8 millimeters of mercury. If the wrong cuff size is being used for your arm, that also can cause a falsely elevated blood pressure. And most of the time, that's from a cuff that's too small for the arm size that it's being used for. If the cuff size is too large, that can cause a blood pressure that's too low. We always ask that people sit with their back supported, so a chair that has a back so that you're not using your muscles to hold your upper body upright. So having a back that is not supported by a chair back can raise your blood pressure. The blood pressure cuff not on bare arm is one of the ones that I frequently get the most upset about when I see it happen because it really can have an enormous range of impacts. And this, I'm wearing a sweater right now that's a relatively thin sweater, but it's a tight sweater. And so, you would not want to measure blood pressure over the sweater, but nor would you want to push this sleeve up because I don't know how well it comes across here. But what I've done here is created a tourniquet, essentially. I'm putting pressure on my arm and pressure on the blood vessel. So you don't want to check blood pressure underneath this because it's going to be higher. And if you check it over the clothing, that's also going to potentially raise the blood pressure. And so one of the things that I'll talk about in the next slide is what can you do better when you go to the office to get your blood pressure measured is to be prepared to have a bare arm without any constriction. Interestingly, having a full bladder can raise your blood pressure. Where your arm is in relation to your heart can change the blood pressure. And then being in a noisy environment, talking yourself or having someone talk at you or to you or loud noises in the background all can raise blood pressure. So some tips for how could you do better when you go to see your doctor? As I mentioned, you want to be prepared. Either wear loose clothing or short sleeves or a tank top under something else so that you can really have that bare arm or be willing to get into a gown. As we mentioned earlier, when Heidi was asking that question, definitely bring your own home blood pressure cuff to make sure that it's accurate. If you arrive early, then you have time to empty your bladder if needed, and then you want to leave some time to sit quietly. Moving around raises blood pressure, and so we ask that people be seated for a minimum of 5 minutes, ideally longer. And then always advocate for yourself. I love it when the patients who come in say, and this happened last week, one of the patients said, I think my blood pressure would have been lower, but the person who was checking it was talking to me the whole time. And I love that because it is much needed education for our staff. And you're advocating for yourself to make sure you're not going to be prescribed medication that you may not need if your blood pressure is lower than it was when you first came in. And then if your blood pressure is high, ask for them to repeat it after waiting for a while. It's most often lower after waiting. All right, let's do this. I'm going to go through the steps. I initially thought this webinar was going to be the type of situation where I could see you doing it yourself and we could give you some pointers or feedbacks, but I'm going to go through the different steps here. And then I actually have some blood pressure cuffs that I can demonstrate. I don't know, Anna, do you have any there?
I don't have any.
I am not well dressed, as I have pointed out. I did not wear the right clothing to do a proper demonstration, but
No, I'm at home, so
yeah, these are the steps. Wait 30 minutes after eating or drinking, or I usually just tell people do it first thing in the morning before you eat breakfast or have coffee. Empty your bladder, as we mentioned. Step 2. Find a quiet spot and turn off all of the screens. Step 3. Sit in a comfortable chair with your back supported and your feet flat on the ground. You want to rest your arm on a table or on an armrest so that it's at chest height. The cuff itself really should be at about heart level. And as I mentioned, you want to make sure that you're placing the cuff on bare skin. Wait 5 minutes, at least 5 minutes, sitting quietly, and then check your blood pressure. Record the numbers, wait 1 minute and check it again and record those numbers as well. So those are the general steps for how to do it each time. We typically recommend that for at least 1 week out of a month, that patients check their blood pressure at least 3 days, up to 7 days in a row, in the morning and again in the evening in this way. So that's really 4 blood pressure readings in 1 day, 2 in the morning and 2 in the evening, for at least 3 days, up to 7 days each month. And then we usually use an average of those readings to help interpret those home blood pressure readings, because as we've mentioned before, there is a lot of variability, both based on time of day and things like that. So we'll use an average of those numbers. I do have a couple here. There's some questions in the chat, and I don't know if you, do we want to take the questions, or I can show, I've got some home blood pressure cuffs here.
let's see. Should we take the ones relevant to the home technique? If there are any about the technique.
Already answered was how long you should wait. If you're taking your blood pressure at home, how long should you sit quietly? And I think you answered that for 5 minutes.
All right, and then maybe I'll stop sharing and you want to do the demo?
Sure. Is there... This is one of the types of blood pressure cuffs that we do usually recommend. It's called Omron. People after the Omicron variant of COVID, they say, "Oh, I've got that Omicron blood pressure cuff." I don't think it's Omicron, it's Omron. But this is one. There are also, this is A&D, which is another type of validated blood pressure cuff that we recommend. This one has something that's called a comfit cuff. So you can see that it has almost like a hard shell. This cuff is sometimes easier for people who live alone or have a hard time just sort of manipulating the cuff onto their arm. This one can be a little bit easier to get on yourself. The other type is what's called a D-ring, kind of like a D-ring binder. It has this A&D has this type, and you know, it's got it has more of a you have to sort of get it onto your arm and then, you know, pull it tight around that, whereas the comfit cuff sort of snaps around your upper arm. If I can do this in a way that we're going to pretend, if anybody on this webinar tells anyone that I measured my blood pressure over my clothing, I'm going to deny it. This is like the cardinal sin in my world. But here is the blood pressure cuff, and we're going to slip this on. You want to make sure you get it over the elbow so that you can fully bend, extend and bend the arm like this. I see people sometimes will put it on here. This is not correct. It wants to be at least about 1 inch over the crease of your elbow here. And then you want to be able to fit just 1 to 2 fingers. It should be snug when it's on you. so that you can only fit 1 to 2 fingers in there, both at the top and the bottom. A little bit about how do you know if it's the right size for you. If you go to order them online, or if you look at them in the store, the cup should have a range. This one here, I don't know if you can see this. This one says it fits our upper arm sizes between 9 to 14.5 inches or 23 to 37 centimeters. And so you can measure your arm with a flexible tape measure. You want to measure halfway between your shoulder and your elbow, around the middle of your arm. This is the diameter right here of your arm is what you're measuring to see if the cup is appropriate to fit for you. And if your arm size fits into that range, then that cup will fit your arm. If your arm is above the range that's on there, there is one good home blood pressure cuff that's made by a company called Welch Allen. It's the Welch Allen 1700, and you can purchase a separate blood pressure cuff that's specific for that machine for another $25. So it's $125, but it's the best home blood pressure cuff that's out there for people who have larger arm sizes. So that's a resource, and that's available on that website that I mentioned. You can look that up. So again, back supported, feet flat on the ground. My arm is supported here. Usually you'll see recommendations to have the palm facing upwards. And then you want to rest quietly, push the button to check your blood pressure, stop talking before you do that, and then wait another minute and repeat it. So those are some of the tips for checking your blood pressure at home. What specific questions do you have about the technique? Anyone? You can chat them in the Q&A. Anna, anything else I missed?
No, I thought that was great.
Don't you tell anyone that I did this over my clothing, right?
I didn't see it.
Just one question in the Q&A. Blood pressure is higher in the evening and pulse is low. Is this normal?
Yeah, so blood pressure certainly does vary throughout the day. And, it depends on what medications you're taking and the timing of medications. But I think overall it is normal to have, some variation.
Like Anna said, I would, one of the things we think about when we see that pattern is what the medications are that are being taken and the time of day that they're being taken. So sometimes we'll make adjustments if we get information like that. But that's why we ask patients to check their blood pressure in the morning and in the evening. And we usually ask you to check your blood pressure before you take your medication. And so you're really seeing that morning blood pressure is, the first thing in the morning after, you've woken up. And then same thing in the evening, you would take your blood pressure before you take your evening medications if you take any. And that information is really valuable for us because it gives us some information about how long your medication is lasting. The normal pattern, I would say, is to have a higher blood pressure in the morning, but that's untreated, off medication. So if you're taking medication, that may not apply to you, but for people who aren't medicated, it's more common to see high blood pressures in the morning. That's the result of sort of the natural cortisol in our bodies that's elevated in the mornings. How are different medications different? Dr. Krawisz alluded to some of this. Different medications work on different sites in our body and are often complementary or even synergistic. And so sometimes you can take two medications with two different mechanisms of action or two different ways they work and end up taking a lower dose of both of those medicines than you would if you had to take the highest dose of one medication. And the advantage to that, even though it may seem discouraging to take two different medications, if you can take lower doses of them frequently, oftentimes the side effects or potential side effects from medications are dose related, meaning that they're more common at the higher doses. And so if you can take lower doses of the medications and they're working in synergy with different medications, you often have fewer side effects. And some of those medications are actually combined into what we call combination tablets or combo tabs, so that you might have two medications in one pill. So you only have to take one pill, but it has two medications at fixed doses that are in it. There's a question about taking medications in the morning and the evening. Which one is better? Anna, do you want to take that?
Yeah, so overall the answer to this one is, whenever you're, however best to treat your blood pressure. Blood pressure goes down during the night physiologically for many people, not for everybody. So, overall, I recommend that patients take them in the morning. It is fine to take them at night. And there's some data, for a while that people are favoring taking them at night. I certainly don't favor taking them at night over taking them during the day. And I generally recommend that people take them in the morning for sort of what Jen describes, sort of the natural physiology of the body, which is that blood pressure tends to rise, right away in the morning. We have something called the morning surge. Blood pressure goes up. And so generally people have higher pressures during the day. And so I treat them during the day. But I also prioritize medications that last for a 24-hour period. So that's a really important thing we look at. When people come in, are they on medications that last a full 24-hour period? So overall, either way is okay, as long as the blood pressure is well treated.
Great. Any other questions? All right. Well, I have just a few closing words. I just wanted to thank Dr. Cluett and Dr. Krawisz, and special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for sharing this important information about blood pressure and heart disease prevention. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website. And if you have any questions about JCC Greater Boston's programs, you can email me. Again, my name is Heidi White. My email is hwhite@jccgb.org. Thank you so much, everyone.
Thank you, everybody. Thank you so much for having us.
Welcome. My pleasure. Thank you.